I think if there's one thing, if there's one piece of knowledge that somebody passed on to me years ago that I think has really taken me a long way, it's open up your mind to things that you don't align with your views. Because I think a lot of us get stuck in these silos and get stuck, following our biases. And it's very easy nowadays to read everything that supports the way we think and, push away everything that's different. But when you start exploring outside of that box, outside of your silo and your biases, you start capturing some of this evidence, and it really is able to mold you, throughout as evidence comes out into these different roles and, make you understand things you wouldn't understand otherwise.
Up next on the show, we're joined by a clinician, educator, and researcher who's helping to shape the way we understand pain and manual therapy, particularly within the veteran population. Dr. Damian Keter is a physical therapist at the Cleveland VA Medical Center, where he's not only treating patients, he's also conducting research and educating others on the complexities of pain science. His research focuses on how individual patient factors, such as psychological, social, and environmental influences, affect treatment responses. And he regularly lectures on these topics nationally. Today we talk and explore Damian's work at the intersection of pain science and manual therapy, dive into his clinical research, and learn more about the unique challenges and rewards of working with veterans at the VA. We'll also discuss the broader implications of his research for clinicians working in orthopedic manual therapy. This is Hands On, Hands Off. Damian, welcome to the show.
Thank you for having me.
You work in a unique setting. You work as both as a clinician and researcher.
Yes.
at a VA,
yeah.
And that's different. That's a different environment. I've never worked in a VA, but I've heard from people like, well, they sort of make this exhale and like, well, it's a little different in the VA because there's different rules and different physics. How do you balance both of those roles, both clinician and researcher, and how does your clinical work inform your research, and then vice versa?
Yeah, that's a great question. It's actually really challenging. I mean, originally I was a clinician. I moved into my PhD work, and then kind of pulled me towards research, obviously. And then as I went into that, all of that stuff was a side hustle, an unpaid side hustle,
right.
And so with that, it was all I did the 40 hours a week in the clinic, and that stuff was all separate. And so then once I finished my PhD work, it kind of just felt natural to still do all the clinical stuff, still see patients 40 hours a week, but still do this other stuff during my lunch, before work, after work, that type of stuff. So that's where I'm at now, is that stuff's kind of in my, the filler time in between patients, but in the morning before patients, that type of thing. And it's interesting because a lot of the stuff we see in research, and we know research, you can't always apply that directly to every patient in front of you. So
Right.
I see that side of it. I see the research side of it, but then I understand that clinician side of it as well, which I think is, a benefit, but at the same time also it's a challenge.
What are the challenges? Just not being able to apply it directly? Because you live and dance between two worlds, right? Which we often hear, which is, well, the academics don't understand us clinicians,
Yep.
and the clinicians don't understand us academics. And while this might be true, you got to figure out how to understand each
Yeah.
other, or neither of you will progress.
Yeah, and I think Roger Chio said it really nicely at this conference when they're talking about clinical practice guidelines. Clinical practice guidelines are the highest level of evidence for saying this is what you should try with patients. But then you have those patients in front of you in the clinic that you say, none of this stuff, none of this high-level evidence has worked or is appropriate for this patient, so I have to jump to this thing that might not be recommended, but it works for this patient. And so I think that's where it's kind of, being able to understand the value of research, but also the limitations in the clinical setting. That's why case studies exist.
Right.
Because you have those patients that this isn't your average patient, and research bases it on this is your average patient. And, who's the average patient?
Right.
I don't see them. I work at the VA, like you said. None of them are average patients.
Right. I heard a great explanation of why average doesn't work, and I heard it actually in communication school. And the professor asked everybody in the room, "Hey, who here likes iced tea?" And, half the room raised their hand. And who here likes hot tea? And the other half of the room raises their hand. And he said, "Great, the average person likes lukewarm room temperature tea." But
Absolutely.
of course, no one likes lukewarm room temperature tea. But that would say average. So understand that average doesn't mean mean, but it doesn't mean real sometimes in
Absolutely.
that way.
Absolutely.
Let's talk about your research. Your research focuses on how individual patient factors influence treatment responses, particularly here at AOMT in manual therapy. Help me understand what some of those key factors are, and then how they affect outcomes in patients with chronic pain.
Yeah, so they have this idea of contextual factors, and Jeremy Lewis spoke on it a lot on his keynote here. Is this idea of we've learned the value of these contextual factors, how somebody feels, what their psychological status is, any anxiety, depression, expectations, what their previous experiences are, as well as their overall health. If they exercise, if they sleep, all of these things. And what we're finding is we used to think, well, these things might matter, but my treatment is really the important thing. What I'm actually doing here. And then over time, we're slowly realizing that those factors mean a little bit more, a little bit more, a little bit more, and that our specific treatment things mean a little bit less, a little bit less. It's not saying they don't have any value. Absolutely. We know these things still have value, but even from a mechanistic standpoint, we currently have a commentary in the International Journal of Osteopathic Medicine that looks at how these contextual factors actually influence what's called the mechanistic responses to manual therapy. What that means is, it's not just that psychological issues, influence your pain response when I push on you. Psychological issues are able to influence your inflammatory response that occurs when I push on you. And so we know that these actual changes that occur with things like manual therapy or exercise or anything else for that matter is influenced and moderated or sometimes even mediated by these different factors. And so, a lot of my research area or my research expertise is looking at this idea of, what factors do we need to look at? How do we leverage these patient factors through things like person-centered care? How do we leverage these patient factors to kind of work along with our technique factors and what we want to provide, rather than that more prescriptive nature of the old school PT where it's this is what I'm going to do because this is what I saw during the eval and I don't care how you slept, if you smoke, right, and all of these other things. It's more of working together with them through some of that shared decision making and things like that.
It's really funny because the AMP conference here at the center that we're at in Orlando, did you see what the group next to us is? Yeah. The next conference that some people have been trying to sneak in. Yeah. It's lifestyle medicine. Yep. I was like, man, a lot of these discussions feel like they're starting to cross over,
right,
which has got to feel good. I don't know if these things were as stressed when I went to PT school, which was not even 10 years ago. Yeah. I feel like they're becoming more frequent and a little bit louder now.
Absolutely. And I think that kind of comes along with, we talk about the biopsychosocial model. And obviously, that term has been beaten over 100 times now. But, I think there was a long time where people used that term and they said you have to understand these things, but we didn't understand why. It was, you got to understand that there's biological, psychological, social things that are going on with the patient in pain or whatever else. Okay, great. But now we're starting to realize why those things actually matter. These things actually influence response. These things actually influence pain. These things actually influence, recovery after even things like surgery and things like that. And so I think the more we understand the why behind that model, the more it's becoming evident in PT school education and medical education overall.
Yeah. You talked about the unique patient population you have at the VA where you work. You treat veterans. What are some of the specific challenges that you face that maybe someone who doesn't work at a VA maybe wouldn't understand as intimately, especially in the area of chronic pain? And how does manual therapy fit into that population's care plan?
Yeah, our population, we have a lot more of the comorbid conditions, which we know influence pain. I work in a couple different programs at the VA that work specifically on addressing chronic pain and teaching others how to address chronic pain issues. And so it's a challenge because we know these things, a lot of the things we deal with are things that people deal with in the private sector. We just deal with it at a higher prevalence. We know more of our patients are dealing with some of these things. We know the pain prevalence is higher in the veteran population. We know it's one of the primary reasons that veterans come into the VA hospitals is to address their pain complaints. And so from that standpoint, I think our patients just have some of those things amplified to some degree. And I think with that, we have to leverage those contextual factors and leverage the influence of those things perhaps more than other individuals. It doesn't mean that it's a hands-off thing. It doesn't mean we have a number of great fellows working in the VA. We have, great manual therapists in the VA, and I use manual therapy frequently. And I think it's a great tool in the toolbox. And when you understand the biopsychosocial model, contributing to pain, but you also understand the biopsychosocial, influence of touch and influence of hands-on things and what we are doing, what the mechanisms are that are occurring when you put your hands on a patient, it makes you appreciate that these things mesh together really well. And, as we move away from this very pathoanatomical rationale for manual therapy working, it used to be I'm moving this joint, I'm doing these things. We've moved past that. We all know we've moved past that. And so as we move away from that and we say, we know there's these neurological changes in the brain and the spinal cord and all of these different areas. We know there's these, neuroimmune changes, inflammatory markers. We know all of these things occur. You start realizing that these same things occurring with hands-on techniques or exercise or some of these other things are also the same things that are influencing pain in a different way. And so you start realizing a lot of the stuff we're doing is just modulating these same mechanisms which are contributing to pain through various different means. And so, in our population, I think as you understand that and you look at treatment across all the treatments, education, like I said, exercise, everything, as you look at the treatments you're providing through that lens, it helps you realize what the place of some of those things are in our patient population that has some of those comorbid. And then obviously, working with the chronic pain populations, it's a lot of interdisciplinary care. We have a lot of interdisciplinary care teams. It's a big emphasis there is this idea of, some of these patients we just can't handle ourselves, and we shouldn't have to, and for some of these real complex patients, we have to pull in other individuals to help us.
Sure.
And we have to be able to, I think that's one of the things that truly, identifies a master clinician for me is somebody who's able to manage a lot, but also able to admit when, hey, this is something I'm going to need some help with, and pull in some individuals, outside of their scope that are able to address some of these.
Let's talk about some more of your research. You published and lectured nationally on pain science and manual therapy, appropriate here at AAM. How do you ensure that the research you conduct is translated into practical strategies? Again, bridging that academic to clinical, so they can actually use it to change outcomes.
Yeah, that's a great question, and I think that's why I try to do some pieces that are obviously more quantitative, qualitative, data based, but I also try to do some editorials, try to do some commentaries. We had a great JOSPT open commentary we did on person-centered care and manual therapy, and we even included a case study in it. And so I think that's absolutely critical. It's linking the evidence to practice, and I think we've really tried to do some research, that's more geared towards, hey, here's the facts, here's the data, and then also wrote up some of these editorials and viewpoints that are, ways to put that in kind of a spoon-fed, way that clinicians can take this and say, oh, that's what this actually means. Because it's a challenge. There's a lot of great research out there that clinicians are never going to know what the heck it means. Because simply put, you read this and it's like, this is geared towards a researcher. It's great stuff, but clinicians aren't going to be able to take this in and understand it.
Is this applicable to me? Yes or maybe no. And if it is, can I understand it? And it's not an intelligence thing. It's some things are dense. Some things are written a certain way. And if you can't use it, man, why don't you make it? Right? If I can't apply these things. Right. And sometimes you do editorials, you do papers, sometimes you do podcasts. Sometimes we actually just have a conversation about these things.
Right.
What about the future? We talked about, past and present and where you are now. What about the future? What trends or emerging ideas or concepts in pain science, manual therapy, any of those, are you most excited about?
So, I'm involved in a couple NIH working groups that are really looking at mechanisms. It's this idea of the why. Why are these things working? Why do people experience pain? Why does manual therapy work? And so we have a couple really big projects coming out there that are really trying to frame, more specific to manual therapy, but really trying to frame what's actually occurring and, what things influence that from a contextual standpoint as well as from an actual hands-on, specific standpoint. Outside of that, I think it's a challenge because I kind of live in two worlds right now. I live in that world of a lot of the mechanistic hands-on stuff as well as in the education aspect of manual therapy. So we're also working on a competency-based education project where we're trying to come up with how to move manual therapy education forward to match some of the stuff we just talked about, right? We know that things have changed. We know that overall in PT profession things changed. And so as we know things have changed, education has to follow up with that. And so we're working on a couple projects right now to try to facilitate, orthopedic manual physical therapy moving forward to capture that stuff, to capture that current best understanding of what's occurring, what's not occurring, and, what we need to consider.
Yeah. Last thing we're doing with guests on the show as we record live here at AAM's Conference 2024 is what we call the parting shot. What do you want to leave with the audience with? Is there an idea, a concept, a soapbox statement, a mic drop moment you might tell people? What's an idea you want to leave?
You said parting shot. I'm looking for bourbon.
We don't have anything right now. Of course, we're recording this now. I wish there was, though. We're coming to the end of our interviews for today, but
I think if there's one piece of knowledge that somebody passed on to me years ago that I think has really taken me a long way, it's open up your mind to things that you don't align with your beliefs. Because I think a lot of us get stuck in these silos and get stuck, following our biases. And it's very easy nowadays to read everything that supports the way we think and, push away everything that's different. But when you start exploring outside of that box, outside of your silo and your biases, you start capturing some of this evidence, and it really is able to mold you, throughout as evidence comes out into these different roles and, make you understand things you wouldn't understand otherwise. And so just keep an open mind and, get into some of that stuff you don't really think you would like and check it out and see what you think.
Yeah, you never know.
Yeah.
Damian, appreciate the time here at AM 2024.
Yeah. Thank you for having me.
Yeah.
Appreciate it.